So I think this is basically to show that lung cancer is responsible for 11% incidence of all cancers and 18% mortality. So which is unlike COVID, where the recoveries are exceeding, the number of patients in India at least. So, lung cancer still remains a huge unmet need at this point in time. Next, please. So I think this is what it is. Next, please. So I think we're going to be focusing on the first line options. Next, please. And we have these first generation, second generation, and third generation, and the debates are always on as to which one should be given in the present day. Next, please. Next, please. So we're focusing on osimertinib as first line, and this is the NCCN guideline where osimertinib, being category 1, has also been given the preferred drug for EGFR mutants, although the other first and second generation EGFR TKIs have been advocated in the front line as well. Whereas if a patient has been started on chemo, when you have a discovery in between of EGFR mutation, you can always interrupt and, or do a maintenance therapy if somebody is responding well to chemo. So I think that basically is the main premise, but then let's move ahead and go through some of the data. Next, please. So these are the three generation of drugs we all are aware: gefitinib, erlotinib, first generation; second generation, afatinib and decometinib, which not only inhibits EGFR sensitizing mutations, but also rare mutations and HER2. So unlike the first generation. Whereas the third generation is mainly looking at EGFR sensitizing mutations and T790M resistance mutation. The first generation and second generation also inhibit the wild type EGFR. That's why it is responsible for so many side effects on the skin and the GI tract. This is irreversible inhibition, and the latter two are irreversible. So I think these are the main differences between the first, second, and the third generation. Next, please. So I think this is to show that there is inhibition of T790M, some activity against, very little activity against, as I said, wild type EGFR. I think what has really brought the whole thing into focus is the ability of this drug to cross the blood-brain barrier in humans and in the preclinical model. Next, please. So I think this FLORA study, which is being discussed time and again, I'll just go through these slides and maybe make a few relevant additional points. Next, please. So I think this was a study design between osimertinib and the first generation TKI, 1-to-1 randomization, and nearly 279 patients. So I think the important point to understand is that patients who were on first generation TKI, if they had PD and they had T790M, they were sort of allowed to take osimertinib. And nearly 50% of these patients who progressed on first generation had the opportunity to take osimertinib. So this is an important point, because the survival curves are dependent on such use of osimertinib or not. But here the crossover was allowed. And these patients had, these exon 19 and L858R, and race could be Asian and non-Asian. And the primary endpoint was PFS. Next, please. So it was very clearly met with, as we all know, 19 months versus 10.2 months. And it was the hazard ratio 0.46. Next, please. And you can see across various points in the forest plot, whether CNS metastasis, the type of mutation by ctDNA, smoking history, Asian or non-Asian, they were all benefiting, and you can see that the unity line is pretty far away. Next, please. So that was what people were waiting for, overall survival. So this is the first time a particular single drug has shown the survival advantage with a hazard ratio of 0.799, 38.6 versus 31.8. So this is a landmark study for first generation TKI. Next, please. Next, please. So at 3 years, you can see clearly here, 28% versus 9% patients were on the drug, and 22% versus 5% are still ongoing treatment at the cutoff of the data. So this is a remarkable achievement with osimertinib. Next, please. And the time to first subsequent treatment was a huge difference, 26 months versus 13.7 months, with a very nice hazard ratio of 0.478. So this is a real, a game changer. Next, please. So you can see the progression-free survival is the best with the third generation TKI, osimertinib, and the others are sort of lower. Next, please. But this is a cross-trial comparison, which may not sort of hold good. So as I showed you, PFS, similarly, the overall survival is again showing, the benefit for exon 19 and for patients with CNS metastasis. We'll go into that a little bit later by the EGFR mutation. So there is a little crossover over here, but then the study was powered for PFS, which was the main, the first point of study. Next, please. These were secondary points. So I think this is what we said. So there is consistent PFS data in which all subgroups favored osimertinib. Next, please. So coming to the first generation TKIs, what information do we have? So I think we all know the PFS data to the tune of 8 to 10 months, and the overall survival, ranging from 21 to 18 months or so, and no difference between the comparator versus the first generation TKI. And therefore, these studies were really, although they gave you the benefit of no side effects from chemo, but then did not offer any overall survival benefit. Next, please. So then the second generation TKIs like afatinib and decometinib. Next, please. So this is a comparison sort between Archer 1050 for decometinib and Flora. Just rush through these. So there were fewer patients in Archer, and these are the patients included from the Japanese versus Chinese, whereas in this we had a whole Asian group and more number of patients in the Flora. Next, please. So I think the interesting point in the Archer was that they did exclude patients who had brain or leptomeningeal metastasis, and whereas patients with stable CNS metastasis were included in the Flora. So they actually, Archer had a better prognosis patients because they excluded those patients who had brain involvement. Next, please. So this is the PFS curve, as you can appreciate, between decometinib and gefitinib, 14.7 versus 9 months. But look at the shape of the curve. The curve is beginning to separate almost at 8 months, whereas if you look at the osimertinib Flora curve, there is almost, within 1 to 2 months, there is a clear separation. So indicating the efficacy of an early efficacy of osimertinib molecule. Next, please. Next, please. So these are the shape of the curves for the overall survival benefit. I think so. That is the Archer, which says 34 versus 26 months. Although this is difficult to interpret the end of the curve because of low patient numbers, because in this group of Flora study, there were a larger number of patients. Next. So I think the trial had a hierarchical stratified statistical design, and given that it did not meet significance in ORR, well, that was not given to OS. These are statistical issues which were voiced in the current Oncology in 2020 April. So I think there's a war going on between those two agents. Next, please. So I think this is the summary of Archer and Flora. And I think I've covered most of the things. The interesting point here is to demonstrate or show the side effect profile of decometinib. You see 66% dose reduction versus 27% and serious AEs. And if you look at osimertinib, so very little. So I think this is one important issue, especially when it comes to elderly individuals as well. And CNS metastasis was another issue. And in spite of including CNS metastasis, they had an OS advantage. Next, please. So this is to show the afatinib, which did not show any overall survival advantage. And decomitinib I've already shared with you. And I think they're looking at statistics to say that decomitinib perhaps did not give you that OS which was expected. Next, please. So I think we've shown these curves of PFS, again, even in decomitinib and in Lux Lung. You see there's a significant overlap of the curves for at least initial 6 to 9 months, whereas osimertinib is, doing the work pretty early. And here, no brain mets, here 16% stable mets, and here 19% brain mets, stable brain mets were included. Next, please. So now looking at the brain metastasis, next please. So osimertinib is really an amazing drug because it does cross the blood-brain barrier. Next please. So I think just skip this. Yeah, next please, next. So I think these are the preclinical data where you can see the, the molecule entering into the brain, as is highlighted here on the radioactive, molecule. So this is the preclinical data shown in the animal model. Next, please. So I think the FLORA study did have an analysis of intracranial efficacy of osimertinib because there were patients included with CNS mets. Next. So as you can see here, patients with known or treated CNS mets, 53 patients, and standard of care, which was first generation TKI 63. And you see the hazard ratio on PFS is almost as good as for the entire group. So which is, indicating that how effective this drug is in penetrating the CNS and therefore delivering the result as it would for a non-CNS disease. So the CNS progression, I think the next slide, please. So again, you see the progression-free survival is not reached for osimertinib versus 13.9 months and the hazard ratio 0.48. So this is statistically significant in favor of osimertinib. Next. So this is the point that the CNS progression was reported in 43% while being treated with EGFR TKI, because we all know that the EGFR mutant patients have a higher incidence of traveling into the brain. And because of its efficacy in the brain, osimertinib is able to check that more effectively, 19% versus 43%. Next. So therefore, in patients with newly diagnosed brain metastasis, osimertinib is the only drug for EGFR mutant which has been approved when lung cancer is the primary tumor. Next, please. So a word about uncommon mutations. There is data which is evolving and emerging. Next, please. And as you can see here, the response rate is to the tune of 51%, and the disease control rate is 89%. So it can be used even in patients with uncommon mutations. Next, please. So tolerability profiles, I think we already said that. Next, the osimertinib is so well tolerated. The discontinuation rate, although was 15% versus 19%, but the grade 3 or more adverse events were like 18% in the osimertinib and 29% in the comparator arm. So median exposure was 20 months versus 11.5 months in favor of osimertinib. So pretty well tolerated. I think we all know, I think everybody is using osimertinib first or second line, and therefore we are aware that the toxicity is in the form of rashes or some kind of diarrhea. Otherwise, the drug is pretty well tolerated. 3%, 1%, the grade 3-4 side effects. So this is again the side effects as you see here, 66% as I showed you. Next, please. With afatinib 41%, and with EGFR TKI 4 to 5%. So it's much, much better tolerated, as we all know. Next. So I think the safety features I've already covered. Let's go to the next slide. I think we all understand the interruptions are more frequent with a drug like decometinib, and I think it may be difficult for elderly people to take the drug because of the high incidence of diarrhea, rash, and other toxicities. Next, please. So I think next, please. So this is, I think we all understand that, the idea is to give the best drug, which gives you the best PFS, and also is responsible for reduction in the numbers of CNS metastasis. Because if somebody is put on a first or a second generation TKI, and then if he or she develops brain metastasis, I think it could be, a disaster for that particular individual, especially if they are lacking T790M. So because the 50% patients are only going to be T790M. So I think it leaves us, no doubt that osimertinib is an important drug to be given to virtually all patients who can afford in the first line. Next. However, next please. And there are significant dropouts, as we all know. So, nearly 2/3 patients continue on the second line, and there's a significant drop in the third line. So I think you have to put your best foot forward, like we do for CML these days. People are mostly looking at dasatinib and nilotinib. And similarly, there are so many other arguments and agents which are being using in the first line. Next, please, which are more potent. So I think I'll not go into this geotag study because of the reason that it is an observational study. Next. So I think I'm just not going to spend time on this. Although they say that there is a, overall survival is 41 months or so. But these are observational studies unless you have a prospective, properly designed study. So I think you can't really rely on this particular data. Next, please. So I think it's a retrospective study. And so anybody I think would doubt unless it's a prospective study. Next, please. So I think the issue is of sequencing versus using the best drug. So I think it seems to me, whatever we have heard and discussions we've had, so osimertinib, I think, is the first line treatment for patients who can afford. So what else is coming up? Next, please. Yeah, so the combination therapies. So this is another important study for a country like India, where a combination of the first generation TKI and chemotherapy, when compared with JEF alone, has delivered results which are perhaps similar or even better than osimertinib. So if you are convinced on that, although the brain metastasis is to the tune of 17 to 19% in this group, because as we know that these drugs won't cross the blood-brain barrier, so that is going to be a handicap. But then JEF and platinum-based chemo would be one of the options for people who are not able to afford. Next. So we are actually getting spoiled for choices these days because there are so many options: first generation, second generation, third generation, combination. And you see, this is the data from Tata, where they clearly showed the combination of JEF and chemo. Excellent, data here. P-values being highly significant, and actually overall survival not reached, which is just amazing. So if you're really a fan of chemo plus JEF, so kindly go ahead and give it to your patient. Next, please. So, but be prepared for some toxicities, which I think we all are for using chemo and JEF, and there would be some discontinuation as we see with all. Next, please. So I'm just coming to the end of this. So now we haven't covered the combination of TKIs and bevacizumab or ramucirumab. So those combinations have also been approved in Europe, particularly, and but then there is data which is emerging. So like you saw JEF and PEM carbo, so there are studies going on like FLORA2, where chemo is combined with osimertinib. Then I think even in stage 3 non-small cell lung cancer, post-CRT chemoradiation, the LAURA study, and I think we are all aware of the amazing data on ADAURA study, MET amplification, so which is a post-progression, responsible for the progression of patient, Savannah study, and one-line post-osimerity progression resistant mutations in the Orchard study. So now people are looking at now different mechanisms of resistance when patients are exposed to osimertinib in the first line. So I think it is a very, very evolving phase, as I said in the beginning, where new areas which we don't actually understand at this point of time are going to be discovered as more and more patients are treated with osimertinib. NGS is now available to identify various mechanisms of action, and newer drugs are going to be available to look at those. Next, please. So I think that's my last slide to show that there is a clinically meaningful and statistically significant improvement in PFS and overall survival. And I think the CNS activity of osimertinib is something which takes things away from the other first line treatments at this point in time to my mind. So I think with this I can close here, and thank you very much for your kind attention.
Thank you, sir. Thank you for the wonderful presentation.
And yes, Sevanti, thank you.
And, thank you to all the chairpersons as well for gracing us on this evening. I will just take a quick moment to ask Dr. Shyam Agarwal, sir, a question that has come in. So it is a given that osimertinib wins. Is there any scenario where you would not give osimertinib, or is there any scenario where you would see, any atypical toxicities in osimertinib that you may have seen?
So, of late, there's been a discussion on maybe finding a few cases of heart problems, reduction in the left ventricular ejection fraction and leading on to heart failures. So I think that's a learning curve. We were discussing this point in the last few webinars. So I think you have made an interesting point here. So any patient with lung cancer who is deemed fit for osimertinib should undergo an echocardiogram like you were doing for sunitinib and so many other VEGF TKIs. So I had asked what is the mechanism of this, LVEF disturbance. Nobody has a clue, but they say that because of the HER2 overlap, so maybe that interaction is leading to. But if you look at the mechanism of action, it is supposed to be specifically targeting the EGFR mutants. So where is HER2 activity in osimertinib? I haven't seen that. So this is what I heard from, I think, Suresh Ramalingam and maybe another couple of physicians. But has somebody shown in a preclinical model that osimertinib is targeting HER2 new as well? That is only known to occur with the second generation TKIs. So, but the point is that the LVEF does go down in a small percentage of patients, and therefore one should take extra precaution before starting, osimertinib for. I think that should be a take home for all of us.
Thank you, sir. That's a wonderful point. And I ditto that point as well. I've had one case till now where, had a severe cardiac dysfunction. That's a great point. We just have to be mindful. And with that, I thank you again for joining us in and for your wonderful talk.